don't want to waste any minute because we have a really amazing presentation today. So I-STARR and the I-STARR webinar stands for Infrastructure for Studying Treatment and Addiction Recovery Residences. And the I-STARR project aims to develop infrastructure to develop science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder, or as you'll hear us refer to it as MOUD. So today you'll be hearing from two presenters, Mark Perino and Dave Sheridan, who will be discussing changes to 42 CFR Part 8 and their potential impact on recovery housing. So before we dive in, just some quick housekeeping notes about the format of this webinar. So all audience members are currently muted, and we encourage folks to use the Zoom chat function to introduce themselves, to connect with fellow audience members, and to ask questions of our presenters. So we do have an I-STARR staff member who is monitoring the chat, and you know, at the end of the presentation, we'll have a time for questions and discussion. But until then, if you have a question, feel free to drop it into the chat, and we'll be collecting those questions. So this webinar and all webinars in the webinar series are recorded, so that folks who couldn't attend today can watch the recording later. We put all of our recordings of our webinars up on the I-STARR website, so folks will be able to access them there. And finally, also a reminder that there is closed captioning available within Zoom, and you just have to go to the bottom and click the three dots for the more to access the closed captioning. So if you've been to an I-STARR webinar before, you may recall that the I-STARR series is funded by, or the I-STARR project is funded by the National Institute on Drug Abuse, and is part of the larger NIH Helping to End Addiction Long Term, or the HEAL initiative. It's also one of several projects that comprise the Consortium on Addiction Recovery Science, or the CEUs network. So let's go to the next slide. So I'm Amy Miracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at UCSF, or the University of California at San Francisco. The team also includes amazing investigators, co-investigators Sarah Zemore and Lenny Jason, biostatisticians Mina Subbaraman and Liba Lee, communications specialists Diane Schmidt and Dustin Kebzu, and we have a project coordinator for our project, and her name is Quinosia Capitani. Let's go to the next slide. So the I-STARR project activities are guided by an advisory board, and this is a really amazing group of 17 members that represent leaders from across the country. So our advisory board represents recovery and recovery housing leaders, treatment providers and payers, and national policy advocates, as well as researchers and educators. In fact, you'll be hearing from two of our advisory board members today. So let's go to the next slide. So with that, let me tell you about our presenters. We have, again, two of our advisory board members, Mark Perino and Dave Sheridan. We'll first hear from Mark, who is the president of the American Association for the Treatment of Opioid Dependence, or ATOD. Mark has been involved in the delivery of healthcare and substance use treatment since 1974. Do the math there, it's quite impressive. He received both a bachelor's in psychology and a master's in health policy planning and administration from New York University. Over the course of his career, he served as the director of the Gramercy Park Medical Group. He was the president of the National Development and Research Institute, or NDRI, and was the chair of New York City's Health Agency's Technical Advisory Group on Substance Abuse. He also served as the chair of a Center for Substance Abuse Treatment, CSAT, consensus panel for state methadone treatment guidelines. It's actually the very first treatment improvement protocol, or TIP, published for national distribution. In 2003, Mark was the recipient of the Robert Wood Johnson Foundation Innovators Award. And currently, as the president of ATOD, he's responsible for the development and implementation of the association's organizing initiatives. He's also a consultant and educator to lots of different stakeholders, government, community, and business groups concerning substance use treatment and policy. So after we hear from Mark, we'll also hear from Dave Sheridan, who's the executive director, a charter board member, and a past president of the National Alliance for Recovery Residences, or NAR. Dave is also a board member and treasurer of the Chandler Lodge Foundation, which is in North Hollywood, California, and has served for a decade on the board of the Southern California Sober Living Network. He's a national speaker and writer on recovery residence issues, with a particular focus on the development of statewide systems for supporting quality recovery residences. He's also an advocate and a resource on fair housing issues. Dave's professional background is quite interesting. It's in institutional investment management, and he has experience including quantitative portfolio management, investment strategy, and new product development for investment firms and their clients. Dave graduated Phi Beta Kappa cum laude with a BA in economics and an MBA from the Haas Graduate School of Business, right down the street from ARG at the University of California, Berkeley. So very impressive speakers we have today. And without further ado, I want to turn things over to Mark so that we can hear more about opioid treatment programs, 42 CFR Part 8, the regulations that guide them, and recent changes to them. So Mark, I'm going to turn things over to you.
Okay, thanks, Amy. I appreciate it. It's good to be with you. Welcome to all who have joined us, and I appreciate the work that we do with I-STARR and the I-STARR colleagues and all of the partners that you've seen. It's a pleasure to co-present with Dave, and I'm hopefully that you'll get the information that relates to the changes from the Substance Abuse and Mental Services Administration. So for the first slide, please. So this is an important slide. This gives you an overview of how we got into the opioid epidemic. And you will see what's called the four waves, the first beginning around 1996. And you'll see that that was mostly driven by opioid analgesics, or as opioids were being prescribed to treat pain. And the concept of treating pain certainly made sense. The problem is that you had folks that were getting a fair amount of prescription opioids, and they were getting into trouble. And the practitioners prescribing weren't fully aware of the trouble they were getting into. That would lead to the next wave, which was heroin use, and it made sense. ATOD is part of a research group from the Denver Health and Hospitals group, and we've been conducting evaluations on new patient admissions to OTPs since 2005. And by the 2010, after 5 years, we learned that a dominant number of new admissions to the OTPs were using prescription opioids and then using that as a way to access treatment. And it was about 35% of new admissions. But we also found out that was startling that the large number of those people, over 30%, were injecting the prescription opioids. And we suggested that would be a precursor to using heroin, and it was. The third wave, beginning around 2013, dominated by fentanyl, which is still a major issue since about 80% of new admissions to OTPs are in fact using fentanyl. This would lead to another wave in 2019 as an emergence with the psychostimulants. And that's certainly complicated issues because the psychostimulants combined with fentanyl is an extremely dangerous combination. May I have the next slide? So this is a Time magazine slide. This goes back over 20 years. This really traces the beginning of the opioid epidemic with the powerful painkillers. The graphic tells it all, and this really was the inception of what would be the epidemic that we deal with at the present time. May I have the next slide, please? So you get the sense, and Alan Leshner, the former NIDA director, wrote an article in the Issues of Science and Technology in 2001. It's an important issue, and I'm quoting from it. A core concept has been evolving with scientific advances over the past decade. Drug addiction is a brain disease that develops over time as a result of initially voluntary behavior of using drugs. The consequence is virtually uncontrollable compulsive drug craving, seeking, and the use that interferes with, if it isn't destroying, the individual's functionality in family and society. And the medical condition demands formal treatment. And that's completely true. That's been the case since the 1960s and before. But it's important to understand that the use, and we can go to the next slide, that the use of medications like methadone and buprenorphine naltrexone improve the patient's survival. This is true, and this is based on research that's been done over 60 years. It increases retention in treatment, and that is also true. So when medication is combined with counseling and other treatment therapies, patients will improve and remain in treatment. And there's something important to say, something that our association has advocated for since its founding in 1984, that medication in and of itself is not treatment. It is part of treatment. Because remember, the patients come across a threshold with multiple issues, whether it's medical, hepatitis B or C, or HIV infection, or psychological issues of long-term depression or anxiety disorders. And a number of people are using other drugs, including alcohol and psychostimulants, which I've alluded to in that first graph. So it's also important to note that illicit opioid use decreases as the patient stabilizes on methadone or buprenorphine. It's also to keep in mind that methadone and buprenorphine are the predominant medications to treat opioid use disorder in the country. Now, the distinct differences: methadone is a complete medication, which means that it does not have any sort of Narcan or Narcan-like substance in it. So, in effect, you have, the use of buprenorphine does have a dosage ceiling effect, which is roughly about the equivalence of 70 milligrams of methadone. So it's important to understand these distinctions. And so you deal with methadone, which is a full agonist, and buprenorphine, which is a partial agonist and antagonist. Now, you also see decreases in hepatitis and HIV seroconversion. This provides that the patient is not either hepatitis C positive or HIV positive at time of treatment initiation. Long-term study of criminologists is that patients decrease their criminal activities as they stabilize in treatment, concurrently increase employment. And birth outcomes are definitely improved as patients, moms are using methadone or buprenorphine. So that's some of the basic material that you should understand. May I have the next slide, please? And the duration of treatment, which has, been raising questions. Generally, and this is from the National Institute on Drug Abuse, less than 90 days of treatment is very limited in its efficacy, and a minimum of 12 months is generally required for methadone maintenance and also buprenorphine maintenance. And longer treatment is often indicated. And that's why some skeptics have wondered, how long should treatment continue? And the answer is as long as the patient continues to benefit from such care. Keep in mind that you're providing holistic care to people. So, as I've said, you're dealing with multiple problems as the patient enters and then remains in treatment. May I have the next slide? So the heart of this discussion, and I know that Dave will follow, is this change of the federal regulations. These are the SAMHSA regulations, which were updated on October 2nd, 2024 for a full implementation date. Keep in mind that when you go back to the original legislation, which was the Controlled Substances Act and the Narcotic Addict Treatment Act of 1970 and 74, subsequently, that created the federal regulatory oversight framework. It bifurcated the framework operating for the opiate treatment programs, then methadone treatment programs, and there are about 2,020 programs, maybe a little bit more right now in the country, treating about 650,000 patients on any given day. Now, SAMHSA, this significant revision is the first one since SAMHSA got the regulatory oversight as the Food and Drug Administration transitioned to SAMHSA in 2001. And so these revisions represent the first major revisions in 20 years. And so the OTPs had to comply and maintain the SAMHSA rules for certification. In other words, there's no opt-out provision for the OTPs. The OTPs are surveyed by the SAMHSA-approved accrediting organizations. Again, there's no opt-out. And because the federal laws split the regulations for oversight between SAMHSA and the Drug Enforcement Administration, there was a third restrictive element, which was state laws and regulations governing the OTPs. And if the state law is more restrictive, you have to follow the state laws. Now, the importance of this is what we've learned early on since the development and the lead up to the full implementation, certainly since the full implementation, is that SAMHSA did some important things. It eliminated the 1-year requirement for pre-admission for using opioids. So as a result, more people are entering treatment. Now, it does shift the onus to clinical determination and judgment on the part of the OTPs, so you have to be thoughtful. Also, SAMHSA created greater flexibility in take-home medication, which followed on the COVID-19 flexibilities that were begun in 2020 under emergency ruling by SAMHSA. In this particular case, the greater flexibility, patient admissions have increased, patient retention has increased. But again, the clinical focus has to be on the OTPs because they're the ones making the clinical determination. In other words, the SAMHSA regulations provide parameters, but the decision-making has to be within the OTP clinical structure. And additionally, it's important to know that the flexibility in treating patients, making it more patient-centered care, is also leading to greater patient retention. So these are positive findings thus far, and we'll continue to monitor this over the course of the following years. But right now, the SAMHSA made important decisions. And lastly, in an era of fentanyl use, with fentanyl being so powerful as a drug, SAMHSA allowed OTPs in the initial dose to go from 30 milligrams of methadone on the first day to 50. That has also had an interesting and early impact, which means patient retention during that first several weeks as they're getting stabilized in treatment has increased. And these are all positive findings because, as NIDA has found through many of its funded research, as the individual patient is retained in treatment, that individual improves during the course of time. And I've already demonstrated that in a previous slide. So the next slide, please. So there are a couple of major initiatives that our association have championed. One is the development of mobile van units. This is an example of a mobile van in Rhode Island, which is administered by Kodak, one of the leading and larger OTP systems in Rhode Island. And this is an example. There are about 45 of these vans in the United States. We think that's still too few. We know there are financial hardships in opening these vans and some regulatory ones at the state level. However, this combined with medication units, which is a bricks and mortar facility, unlike the van, is certainly a way to expand access to care for treatment for opioid use disorder in the United States. And in this particular case, the vans and the mobile units and non-mobile fixed site medication units must be aligned under the licensure of the OTPs, or opiate treatment programs. Next slide, please. And one of our next initiatives is increasing access to medication in incarcerated settings. And this was an early article that I wrote for the American Jails magazine. This was in 2000. So it shows you this is 25 years ago. Now, the graphics are not mine. That was up to the creative people in American Jails magazine. You will note that it has a sort of slightly sinister look of dark purple and green. It looks like it's something out of an Edgar Allan Poe movie. based on some of his early stories. That notwithstanding, this was based on the Rikers Island jail experience, which at that time was using methadone primarily because that was the only federally approved drug to treat opioid use disorder. And it reported on their early findings, which have continued to this day. And two of the major findings of why we advocate for increasing access to medication-assisted treatment for opioid-using inmates is based on the fact that if the jail or prison initiates the use of medication to treat these inmates, and if they're transitioned upon release to either an OTP or a doctor's office which uses buprenorphine, there's more than a 50% reduction in post-release mortality and over a 55% reduction in recidivism, which means this is intelligent as a policy. It saves a lot of money, and it's very useful, frankly, for the people in the incarcerated setting. And, I don't know if there's any rational person that would oppose this because we save money, the patients live, and they don't return to using crime because it's established by one of the earlier slides that as long as the patient is retained in treatment, well, the patient is going to decrease their use of crime. And great criminologists such as John Ball and Dave Nurko and a series of their criminology consultants and colleagues have learned that over the course of many years. In fact, one of the major bases for why President Nixon and his administration in the 1970s was the singular administration that expanded the use of methadone throughout the country. And in that case, it was because it would reduce the incidence of criminal conduct among untreated heroin users at the time. And there's no question that that was the case, and that reality and that finding has been sustained ever since. And the next slide. So, in the event that you would try to learn more about treatment, our conference is coming up this October 4th through the 8th. It's in Philadelphia. It's a comprehensive 5-day conference with lots of training and opportunities. So you can go to our website. You can certainly contact me if you're interested. And then the last of my slides is how you can actually get in touch with me. If you want to, I've said to Amy and her colleagues at I-STARR, if there are questions that you may have about treatment or what I've talked about, you can certainly contact me. That's my email address, mark.perino@atod.org. May take me a couple of days to respond, but I assure you I will respond to you. And part of what we try to do, not only in advocate, but to explain our treatment system, is to basically get, past some of the stigma which is so powerful that deals with medication. And Dave will talk about that in terms of how recovery-based residences deal with patients who also are using and maintained on methadone and buprenorphine. But from my point of view, the treatment has been sustained since the mid-1960s. Our association works with our international partners, which is the World Federation for the Treatment of Opioid Dependence. My counterpart over there is this terrific psychiatrist, Dr. Ikro Manimani, who's affiliated with the University of Pisa in Italy, and they represent more than 600 programs in the European sphere. And ATOD works very closely with them. In fact, they're co-presenters at our conferences coming up, and we co-present at their conferences in Europe. So I'm again grateful to Amy and her associates at I-STARR for giving me the opportunity to present this information to you. I hope it's been helpful. Also, I think that SAMHSA did a terrific thing in changing their regulations, which, as I said, represents the first major change in regulations in 2 decades. And there's technical assistance available to treatment programs as we increase access to care for opioid use disorder. And there are ways to do this. And from our point of view, it's to do it responsibly, responding to the needs of the patient. Once again, medication alone is not treatment. It's a component of treatment, but you need to respond to the needs of the patients in order to be effective in treating them, retaining them in care, and improving their lives. So thanks again. And if you've got any questions following Dave's presentation, certainly happy to respond. So Amy, thanks again. Hope this was helpful.
Excellent. Thank you, Mark. Now we're going to transition to Dave Sheridan to talk about the impact of these changes on recovery housing.
Thank you, Amy. And it's a pleasure being here today. I should point out to our audience that Amy is also a former NAR board member. So we go back a long way. Um, Before talking about the recent changes to 42 CFR, I want to provide a little bit of background on the current state of medications for opioid use disorder and recovery housing. We're at a point now that's quite different than we were 15, 20 years ago when I started this work. Um, and what has become an emerging consensus, and this is among not only my organization, NAR, but also SAMHSA, the American Society of Addiction Medicine, National Council for Mental Well-Being, and several other national contributors. There's a small handful of best practices that, first off, FDA-approved medications for treatment of opioid use disorder. We can go to the next slide. When they're taken as prescribed, are consistent with abstinence-based recovery pathways. And they're supported as a best practice in recovery residences. Residence providers also need to be aware of their obligations under the Americans with Disabilities Act and also the Federal Fair Housing Act, which prohibit categorical denials of service based on a condition of disability. And more, we're seeing cases and some aggressive enforcement by the U.S. Department of Justice that denying services to someone because they're in a methadone program or are prescribed buprenorphine violate those basic civil rights laws. Now, what we also would like to see, and other organizations are endorsing, is rather than just grudging acceptance of people with medications into recovery housing, we want to see residences be able to support and respond to the unique needs of people on these medications. Next slide. And we'll talk a little bit about what those unique needs are. It's a term we coined in writing a couple of papers, one with SAMHSA backing that we'll get to in a couple of slides. Phrasing we call MOUD capable, which means more than just accepting, but actually actively being able to respond to these unique needs. And those include coordinating work and recovery activities with medical appointments, including OTP visits. Ensuring residents aren't stigmatized. And that's whether it's by staff or current residents, or also community-based recovery activities that are often hostile to people taking opioid medications, particularly these two, methadone and buprenorphine. We also want to see that residences are properly managing risks of diversion, because these medications are subject to diversion, misuse, whether it's residents sharing their meds with other residents or not taking their meds as prescribed and instead converting them to cash in one form or another. Also being able to communicate with prescribers when it appears that something is medically not quite right with a resident, but not acting as doctors. That people operating recovery housing are not medical professionals and ought not be interfering in deciding on things like dosages and when to stop using the medication, those sorts of things. That's a long educational struggle, but one that we appear to be winning. And finally, appropriate drug screening. The really good news is that the technology is now affordable for residences to do point of care testing that isolates the different opioids. So they can tell whether someone is taking methadone as you would expect, or there's some other opioid in their system. The same with buprenorphine. So those have been real big aids. Next slide, please. The most important message in all of this that we can communicate to people taking opioid medications is that their medication isn't their recovery. And Mark touched on this, that medication in isolation doesn't substitute for the process of learning and growing that happens during recovery. And one of the important roles of recovery residences is to span that period of time when somebody has had, say, clinical addiction treatment, whether it's residential or outpatient, that's relatively limited in time, but they need support for that early part of their recovery that can extend out a year or more. And that's where recovery housing really fills a gap. Next slide, please. To the end of trying to crystallize what we've all been thinking, what's happening in the field, we've got two documents available on our website. One was developed for recovery residence operators, and it's a best practice guide for how to support people taking MOUD medications. The other was one we developed at SAMHSA's request for state policymakers. And in the early days of pushing out buprenorphine in particular, they were getting a little bit militant about what they were trying to require recovery housing operators to support and not providing enough education and support. So slightly different messages, different audiences, but both crystallized best practices. And Amy will drop the links to each of these documents in chat for those of you who are interested, but they're available on our website. Next slide, please. So as to the likely impact of the recent changes for recovery residents, well, for us, we're probably going to be seeing increased access to methadone as an MOUD option due to more program flexibility. That more clients are going to qualify for take-home medication, and that means they're going to have fewer constraints on what they can do during their day while they're living in a recovery house. For example, going to work, going to school, whatever it is they're doing to get on with the next stage of their life. Fewer conflicts with work, school, life due to fewer clinic visits. Increased access to buprenorphine will be a result of new prescriber rules. The X waiver requirements have been withdrawn, so medical prescribers with the proper, I think they still require an, what's the agency, Mark, that blesses opioid prescribers?
That's the Drug Enforcement Administration.
Yes, there's still a DEA requirement, but if you have it now, you're not limited in the number of patients you can support. So we're going to see more eligible prescribers, and also the rules include relaxed and extended permissions for telemedicine. So initiating treatment via telemedicine rather than requiring personal office visits also will likely increase access to these medications and therefore demand for support in recovery housing. And we think both of those together are going to be, it's going to be a while before we know for sure, but it's pretty likely those are going to be the main results. Next slide, please. So the other thing that we always like to talk about is these changing incentives. When NAR started 13 or so years ago, the acceptance of individuals taking MOUD medications in recovery housing was pretty low. There's a lot of resistance, a lot of old thinking about medications, not really, meaning people weren't really serious about their recovery. They were still getting loaded. Um, and it's been a long process, but there's a few catalysts that have been helpful in moving more and more operators to being accepting and supportive of people on medications like these. One's been payer and regulatory incentives. A lot of states now are conditioning eligibility for funding on residences' willingness to fully embrace residents with medications. There's a lot more education and support available. And I'd like to point out our 31 state affiliate organizations through NAR have been doing a lot of work for the last almost 10 years, educating providers about the needs for their support and the benefits to the people they serve if they'll educate themselves about the science and learn from other providers who have experience making room for residents on medications with great success. It's a changing legal environment. The Department of Justice has gotten more militant. Several states have gotten fairly aggressive in insisting that service providers of all types, and recovery housing is not by far the only target here. A lot of addiction programs, a lot of long-term return to work programs have been cited for barring people on methadone from participating. And that's starting to see results. But, you know, the main thing is that there's been a real solid history now of successful integration, and certainly at least among our providers. And there's an old adage that success breeds success, and that's what we're seeing. We've got a couple of examples, organizations that have become part of the NAR network that existed prior to NAR's formation. So going back 15, 20 years, these organizations said the vast majority of their operators were not welcoming to people taking methadone or buprenorphine at all. And now those organizations are those providers are the minority. Two organizations in particular had done polls when we started looking into this, and fewer than 15% of their operators were willing to accept someone taking these medications. And now those numbers are approaching 90%. And a lot of that has to do with education and the example of other operators, and really just helping people understand what's the right thing to do and that it can be done. Now, that's not to say there isn't lingering controversy, but what we are seeing is a lot more acceptance, a lot more creativity. And that particularly includes 12-step fellowships. Several of us, from a few from SAMHSA, a few from other governments, and a couple of us from the private sector, shared a panel at the Narcotics Anonymous World Convention several months ago. And we actually received a really warm reception. And our message was, we need you. We need your fellowships. We need your meetings. But a lot of people can't get the full benefit of what you offer when they feel like they're being treated as second-class citizens and not fully in recovery when they come to your meetings. Very, very surprising, positive reception. Some of the other fellowships have been a little more advanced in that, but even Narcotics Anonymous now has developed some literature. And so we're hopeful that integration into the mainstream of recovery is very, very close. Next slide. And this is how you can get a hold of me. I don't have a nifty slide on our annual conference, but it is coming up September 15th through 17th in Sandusky, Ohio. It's the annual NAR Best Practices Summit. I'll have about 500 people, 3-day conference, and you're all welcome to attend. There will be information on our website in the next week or so. Information about how to register, hotel, etc. And Amy, that's what I've got. I'll turn it back over to you. Thank you.
Excellent. Wow, what amazing presentations. Thank you so much, Mark and Dave, for a grounding discussion on MOUD, particularly opioid treatment programs, OTPs, changes to federal laws regulating them, and how this may affect recovery housing. So at this point in the webinar, we actually pull down the slides and open things up for questions, Q&A, discussion. Feel free to raise your hand. I see one from Tim already, and we'll call on you, or feel free to drop a question to the chat because we are monitoring the chat. But we do have a good 10 minutes for Q&A. So with that, I'm going to turn things over to Tim with your question.
Really, I was just trying to applaud our two presenters. I guess I hit the wrong button. I wasn't really
Oh, well, we'll take comments too. That's a good one.
Well, you're so on point, and I am a newcomer to this. You know, I've been in recovery housing for about 8 years, I guess, and 7 years before that as a volunteer for family groups. Because I retired in 2002, I had nothing better to do, and I'm 45 years into recovery myself, and I was wondering if I was just lucky and how I made it, and kept myself busy. And now this is the most rewarding thing to be a part of that I've ever encountered. And Mr. Sheridan, I really appreciate a lot of your work. Yeah, we haven't met, but you are so on point. And with your local group here, I'm in Houston, Texas, that you have with Jason and Jason.
Excellent.
And we saw a lot in the last 15 years here. And we certainly have a change. I still get the question, and I like the way that you frame things very eloquently, but I still get the question weekly from providers that I've worked with for 10 years. Do you take MAT? People. Yes, from day one. Do you take, and I still get from the discharge planners. I mean, it's still a huge question here. And some of the doors that I've had to help keep open with AA and the local, right here in my community, you know, to make sure that we have a fair, and it's just, today was just like Christmas, hearing some of the things that are being reported elsewhere, because sometimes we get our head down and dealing with what we do every day, and stay in the fight and hope we're doing the right thing, and the world is changing around us. And congratulations, guys. And I really appreciate your time, and Amy. Yeah, all the things I-STARR, I-STARR provide. This is a breath of fresh air. The air gets thin out here sometimes.
Tim, I can provide you one of the stories that several of us use with reluctant providers, old 12-step people that just are convinced that they're not, these people aren't serious about getting in recovery. We say, look, you run a wonderful recovery program. You know, people in your program get sober, they stay sober, they contribute to the community. Yet you deny that option to people who really need to see that example. And gotten a couple of people to change their minds because of that.
That's lovely. So going back, I have a question for you, Mark. So I really appreciated the detail and kind of tracking the changes to 42 CFR Part 8. Can you talk a little bit more about the push or the pull to make those changes? And to the extent that you can, what has been the reaction in the field to these changes? Do you have a sense of that?
I do. And SAMHSA was very good in thinking this through and preparing the field It started, the flexibility of take-home medication began with COVID because SAMHSA wanted to prevent greater opportunities for infection. And so the programs carefully started making changes, which were helpful. And, in the entire history of the regulatory oversight for OTPs, there's been a very great conservatism about giving patients medications like methadone. It is, in fact, a Schedule II opioid, so it needs special handling. And but it involved a very important part of our evolution. So we have found that, even with careful monitoring, the programs can provide more take-home medication. And as Dave pointed out, it does free people so that they are able to pursue other parts of their lives, which is important, whether it's work or dealing with family or education. So the field has responded favorably to this. I think the fact that there's more flexibility in also determining initial doses, which has helped because, as people are using fentanyl, and I said 80% plus of new patient admissions are using fentanyl, SAMHSA correctly figured that by increasing the initial dosages, you're going to be better able to engage patients in treatment, and that has happened. I think with the push for other units affiliated with the OTPs, whether they're the bricks and mortar medication units or the mobile van units, they will push out into rural and underserved areas of the country. And remember, change is slow to take effect. Nothing happens, unlike Harry Potter and the use of magic wands, that's not the case in this particular area. And as Dave also pointed out, stigma is a long-held issue. So you're dealing with an environment in general that embraces many of these sort of issues. So the regulations are good. Telemedicine, again, is being used increasingly in the OTPs around admission. Again, it's in its early stages, but it's favorable. And, the fact that you see more jails and prisons offering access to care is also a huge change. I mean, when I wrote that article 25 years ago, we were hitting up against major obstacles. There are still obstacles, mostly funding and how programs can open behind the walls. But as Dave pointed out, it's gradually changing and for the better.
So I know that we often have researchers on this call during the webinar. Is anyone studying changes or the effects of these policy changes? And if they weren't, what do you think that we should look at? What would be evidence of the success of these changes? Do you have a sense of that?
Well, I can respond to that as people are thinking about it, which is, you're going to watch long-term retention and care. You're going to look to see the positive changes in the individual patients. So, will you see, aside from increased retention, will you see decreases in opioid use, especially early on, as the dosages have increased? And will you see improvements in employment as a result of these greater flexibilities? Will you see other institutions, as they learn about the greater flexibility, referring patients to the OTPs? And we're beginning to see some of that. So it's interesting as, the treatment environment and the different parts of the treatment environment become aware of these greater flexibilities, I think you'll begin to see a greater number of referrals coming in. And that means there may be even greater support among other facilities, mental health facilities, as an example, federally qualified health centers as another opportunity to see access to treatment increase. So that's going to be the interesting issue. Do you really see some fundamental operational changes? And the real question will be, do the third-party reimbursement authorities, whether it's Medicaid or Medicare, do they make changes as the patients remain in treatment in terms of funding. And I would argue that those changes would have to be profound in order to continue to increase access to care. And as people on the webinar will understand, right now is a very dynamic time. That's a nice word for it, in the federal government and how the federal government is dealing with these matters. And Medicaid is certainly, on a chopping block potentially. So I, with the Legal Action Center and many of our partner advocates, are working with members of the House and Senate and the administration to avoid any catastrophic effect of drawing back Medicaid reimbursement, because this is not the time to do it, especially as CDC has reported over the last couple of years, the first decreases in opioid-related mortality. So, and that's a gain that took years to get to, years. And a lot of factors related to that, like greater Narcan distribution, as an example, more emergency room admissions where the staff were clinically sophisticated and now knowledgeable with access to other resources. So we want to be real careful as we're making these huge shifts that we do not go back to more of the opioid-related deaths, which have been tragic in this country. So you have to be careful with these hard-won gains, not to reverse course.
What I would focus on, given the this administration, but also just because it's a good idea, is let's start talking about cost effectiveness. Like what we call usual care is a seemingly infinite recycling in and out of outpatient treatment programs and other outcomes which are a lot less rosy. Wouldn't it be better to spend the money up front on medications and recovery support services? So I'd like to see researchers targeting the marginal benefits of these two things relative to what we've been doing incorrectly for 40 years, which is treating a chronic disease, which is addiction, as if it were a broken arm. We put all of our money into acute and subacute care for a disease that takes a year or more to go into remission, and 5 years until people can reach stable long-term recovery. It makes no sense, and there's got to be good research material there on what if we focus on the outcomes for people that are getting these supportive services versus quote unquote usual care. You researchers know how to define that.
Yeah.
And Dave, I really appreciated your slide on kind of what you anticipate these changes or how these changes may affect recovery housing. Well, we can study that. We can study that. That was brilliant.
The other thing is you're going to get a larger sample of people on MOUD medications as these changes and more acceptance from our operators becomes the norm.
The caution that I throw out, and I'm not a researcher, I'm not educated like anyone else that's on here. I come from another profession. However, when I'm studying these, I was successful in business and I know how to read graphs. And the question that I throw out in my NAR training when I'm doing that here regionally is when you look at that in that decline that everyone was applauding, to me, the one question I have to analyze is how many times can you kill someone? Because the deaths, the way that the volume has turned up, the uptick in the last few years alone, when you're going with opiates and the fentanyl and the one-time use deaths and all that gets piled in, it is a new dynamic out there. And so just ponder that. And I'm sure some brilliant minds out there could put that into an algorithm and how it's affected. And so don't falsely report, that there
We're
is
not out of the woods.
Yeah, we're not out of the woods yet.
Well, the other, I don't know if anybody's seen it, but the real eye-opening study to me was the University of Pittsburgh study a couple of years ago, where they were looking to see if our opioid epidemic was an aberration. How did it fit into data going back as far as we've got data? And this goes back into the 1980s. And what shocked the researchers was no, this is just the most recent plot on a curve that's been accelerating since the 80s and probably before, because the data doesn't go back any further that's really reliable. So, we've got cultural sickness here too. Not to mention meth, meth now, for which there's no chemical cure. And alcohol still kills more people than everything else combined, but it kills them slowly. So yeah, we've got a lot of things out there that have been addressed. But Tim, to your point, yeah, how many people are left to kill that were in the high risk sample? The other thing, and this is for the DEA people, the advent of fentanyl and the new formulations of meth mean we've turned what used to be a long-term process of addiction degradation into Russian roulette, where, kids are dying taking 1, 2 pills at a party, not really even intending to get involved with drugs. It's a different ball game when you can kill a city of 100,000 with the contents of a FedEx envelope.
And here in Texas, we have a boom going on with the smoke shops and the synthetic marijuanas. Keep your ear to the ground about how devastating that is. I see it in my clients where they pop, and we are way out there and testing just to keep them safe from that. But the psychosis that's induced by the synthetics that's out there now, and I mean, it's just the next wave. So we need to brace ourselves. We really do need to brace ourselves.
Yep, our work is not done.
No.
I really appreciate this webinar and this discussion, because it just reminds us and invigorates me to do even more work. So Mark and Dave, thank you. I have the unenviable task of switching modes from our Q&A wrap up to things coming up in the I-STARR webinar series. We do have another webinar next month. So we have another one of our I-STARR board members presenting, Sharon Reef. She'll be talking about recovery housing place and health services research. And then in June, we have some more I-STARR board members. We have Roland Lamb and David Pading talking about recovery housing and how that fits into behavioral healthcare cities. Roland will be talking about the behavioral healthcare transformation in Philadelphia, and David Pading will be talking about behavioral healthcare in San Francisco. So I'm really looking forward to our May and our June webinars. So stay tuned. I do want to remind folks that all of our webinars are on the I-STARR website. So if you miss one, you can't make it for 1 month, feel free to go to the website and view the webinar there. When you're on the website, you'll see information about our training series. So the training series is an encapsulated 12 webinars, a set of 12 webinars for researchers, folks who are interested in studying recovery housing, but also 12 webinars for folks who are operators or providers of recovery housing. If you can get through all 12 webinars, you can get a certificate of completion for the training series. You can also be recognized on our website. We have some folks in the webinar today who are part of the I-STARR team, or the team of folks who've completed the webinar series. I won't call them out, but you can see them listed on our I-STARR website. If you complete the provider training series and you do so by the end of this month, by the end of April, you can get a certificate of completion and submit that to NADAC for NADAC CEUs, 12 NADAC CEUs. But you would have to complete all 12 webinars by the end of this month to qualify for that. So again, all that information is on the I-STARR website. If for whatever reason you can't find anything, feel free to reach out to us, and we'll get you connected to learn more about the webinar series and the I-STARR training series. Let's go to the next slide. So some other things I want to alert you to. So the NCARS conference. So I mentioned that I-STARR is part of COARS, the Consortium of Addiction Recovery Science. And COARS presents an annual conference, the National Conference on Addiction Recovery Science, NCARS. That's next week. I can't believe it. Registration is still open. So if you haven't seen anything about COARS or NCARS and you're interested, feel free to go to the website. I'll drop into the chat a link so you can find out more about that. It's going to be, I think, a really nice conference this year. We have some great keynote speakers. We have folks, not only researchers, but we have partners, community partners, and the National Alliance for Recovery Residences is one of our partners, our NCARS partners this year. So Dave Sheridan, our representatives from NAR, will be there and we'll be able to talk to folks about what they do with their organization. So that is NCARS, and I'm just realizing that we're out of time. I think that the next slide is the last one. And just to wrap up, again, thank you to Mark, thank you to Dave. Just an amazing amount of information that you imparted to us today, and thanks to everyone who showed up and made time in their schedule to participate in the webinar series. We hope that we see you next month. Thank you, guys. Bye-bye.
Thanks.